etiology or diagnosis. And ultimately, this was reported from China to the WHO that they had identified this cluster of individuals with pneumonia of unclear etiology. What's really striking is, given the advances in medicine and molecular biology, that a week later, on January 7th, it was recognized that this pneumonia was due to a novel coronavirus. And at that very beginning, our clinical virology team here at the University of Washington started to develop an internal test, which I think was extremely important as we later on began to face this pandemic locally, and really helped us to respond in a manner that, when we at least look at other parts of the country here in the United States, those areas that did not have adequate testing availability really had challenges. Some of you may have also seen in the media, we had challenges here within the US where the tests initially were available through the CDC in Atlanta, but the turnaround time was upwards of 3 to 5 days. And there were some challenges in even getting those tests out to the state labs. And so our own internal test was a critical development that we started very early in the beginning of January. Now, Washington State also had the first confirmed case of COVID-19 in a return traveler back in January, and this was announced on January 21st. This was an individual admitted to a healthcare system just north of Seattle, and the patient was in the hospital for roughly 2 weeks and ultimately did well, cleared the virus, and returned to the community. When at that time, at least here locally, we were really focused on identifying potential, what came to be known as COVID-19 in return travelers. And we spent really I'd say that next month working with public health, developing our processes and being able to identify particularly potential return travelers. And in fact, one of the things that we did here was to set up a home assessment team. And there's a picture of 2 of our physicians and one of the nurses who were helping to coordinate that in the bottom left of your screen. The reason we set up this home assessment team early on was that when there would be potential return travelers in our community that had symptoms compatible with COVID-19, rather than having them come into the emergency department or into the clinic and risk the potential exposure to other patients or staff, we would send this team out to their home or residence, and they would be able to assess the individual and then collect specimens for testing. And we did this probably for that month, from the end of January through much of February. And still at that time, we really didn't have clear evidence of ongoing transmission here locally, and again, focused on return travelers. All of this changed for us at the end of February. And on February 28th, we learned of a high school student in Snohomish, which is just north of Seattle, that had been diagnosed with COVID-19. And this is an individual that had no travel history and had no known exposures to other individuals with COVID-19. And on that same day, we became aware of a cluster of patients at a skilled nursing facility who had been admitted to another hospital here in the Seattle area called Evergreen. And they also, unfortunately, had the first death reported here in Washington State and the United States at that time. Those 2 situations, both the cluster and the nursing home, as well as this high school student, again, none of them had travel history, none of them had known exposure to someone with known COVID-19, really suggested that we now had ongoing transmission within our community, and that it had been there really likely since that first case in January. When they've done further molecular analysis, it actually turns out that there was a second introduction of a strain in early February that then had been transmitting at low levels within our community throughout that month. But that really signaled a change to us in terms of our shift from looking at return travelers to really how do we now manage this within our own community. That following day, our healthcare system, which is comprised of 3 hospitals on 4 campuses, as well as a network of clinics, we activated our incident command system across our system, and then each hospital activated their own incident command as well. We did this for the alignment and coordination of our activities because we knew we had to respond to this as a healthcare system. It also allowed us to partner both directly with public health, with the Department of Health, and our other healthcare systems in the region because we really had to respond to this as a community as opposed to individual hospitals. That following Monday on March 2nd, we received FDA approval to be able to use our internal test that had been in development since early January. And that was such a huge benefit for us. We provided 90% of the tests that were done initially in Washington State and still provide about 50% of the testing that is done in the state. And that quick turnaround, our ability to get an answer within 6 to 8 hours of testing someone really made a significant difference as we began to manage patients within our facility. One of the things that early on was clear to us is that we really didn't know what to expect at that point. And so we worked with our colleagues at the, let me see if I can advance this slide, worked with our colleagues at the Institute for Health Metrics and Evaluation, which is within UW-Medicine. This is a group that was able to model and do projections on the potential number of patients that we may need to be able to be prepared to care for in terms of our surge planning. And this was really critical for us here locally. And then ultimately IHME began to do modeling for all the states and even other countries in terms of that potential surge projection. When we first contacted them, around March 10th and asked them for their assistance, they projected that we could see upwards of an additional 900 patients within our 4 hospital campuses. Now, that both gave us pause, but it also gave us a target in terms of what we needed to prepare for. And so this was incredibly valuable very early on in our surge planning. And this slide just shows at the high end upwards of 900 patients, the median range around 500. And the real question was, could we make an impact to, in essence, flatten that curve? And by flattening the curve, we're really talking about decreasing the peak number of patients with COVID-19. It means it will be sustained over a longer period of time, but more manageable for the healthcare system so that we don't get overwhelmed. And we were very fortunate in those early days that our leadership here within Washington State, I think, did a great job of implementing physical distancing measures very early on in terms of transitioning and closing schools and transitioning to online learning for the rest of the school year. Many of our large businesses, including Amazon, Google, others within our region, also quickly shifted their employees from in-person work to telework. And all of those physical distancing measures, although very challenging and disruptive for our community, really did help us flatten that curve. And in fact, these projections went from over 900 additional patients early on down to 700, and ultimately we plateaued at 122 patients who were admitted at a given time within our hospital system. And so that benefit and that community response to physical distancing was really critical in the early stages, and I think put Washington State in a much better position than many of the other states, unfortunately, within our country. Now, during those early days, I mentioned that we set up the incident-wide command center. We also really did a lot of work around our internal and external communications. We created a centralized website where we could put all of our policies and procedures and useful links so that all of our staff could go to one place to find that information. The other thing, because Washington State was really at the forefront of impact for our country with respect to this pandemic, we felt it was very important to share our policies, procedures, and information. And so we created an external facing website for which you don't need a password, where anyone could view our policies and procedures, because we thought, again, that was very important to share information. I mentioned our testing capabilities, which were critical early on. And in fact, over time, what that allowed us to do and I'm happy to answer questions more about this later, but we began to test all patients who were going to undergo surgery prior to their surgery so that we knew their status heading into that. That was important as we worked with our surgical and anesthesia colleagues to be able to use the appropriate procedures. Obviously, anesthesia was very concerned about aerosol generating procedures with intubation. And so we wanted to make sure that we could do that in a safe manner and also limit the use of PPE when, if we didn't need to use airborne precautions such as an N95 respirator in a patient who is negative for COVID-19 and use our normal processes, then we wanted to be able to do that too to conserve that precious PPE. So that was one of the things that we did early on from a testing standpoint. And then subsequently, and we continue to do this, we test all patients who are admitted to our hospital. That testing capability to know their status while they're in the hospital is very valuable, again, in terms of creating a safe environment for our staff so that we know the status of patients. And we also can then identify if we happen to have someone who later develops symptoms and we retest them, we know what their status was when they were admitted to the hospital. The other testing things that we did early on is that we set up drive-through testing capabilities initially for our employees. So any employee who had symptoms could go through this drive-through testing site. And then we expanded that for our patients. And we used drive-through testing sites that were outdoors, one, because there was better ventilation in terms of limiting that risk of transmission of COVID-19. It also allowed us to preserve personal protective equipment by having dedicated teams in those drive-through settings. And I would just say more recently, the city of Seattle now has set up on both the north end and the south end of the city two public drive-through testing capabilities. We do the testing in our lab, but the city of Seattle is staffing those and collecting specimens from people who show up to be tested. And that, I think, is really important piece of expanding that testing capability. For our surge planning, I mentioned the modeling. We also, when we saw that we may face upwards of 700 or 900 new patients, we realized we needed to build bed capacity within our hospitals as well as to preserve personal protective equipment. So on March 16th, we began postponing elective and non-urgent surgeries and procedures. Our governor later ordered the postponement of those elective and non-urgent surgeries on March 19th, and that extended through May 18th. When we did that, we immediately saw a 65% reduction in our OR volumes that also allowed us to have capacity within our hospitals and build that capacity. Some of our hospitals, such as our county hospital, often are at 100% or more capacity. Those capacities dropped to about 65 to 70%. So it freed up beds to be able to prepare for that potential surge of COVID-19 patients. In our clinics, we shifted from in-person clinic visits to, whenever possible, using telehealth. And I'll show you the data on that. But that was incredibly important, particularly in primary care, because again, the whole goal was how do we maintain that continuity of care for our patients, but do it in a safe manner that really allows them to be cared for, but not have to be potentially exposed by coming into the clinics. We also funneled off patients who had respiratory symptoms to designated testing sites. Now, within the hospitals, in order to meet this surge, we developed staffing pools, both for our physicians as well as nurses and other members of our healthcare team. Excuse me. So for instance, with our physicians, we recognize how do we staff our ICU teams? How do we staff our acute care teams? And we were able to redeploy some of these physicians who, because now we weren't doing as many surgeries, we had more anesthesia staff available to help in the ICUs. We had surgeons who are critically care trained to be able to help in the ICUs as well, because they weren't operating as much during that time. Now, personal protective equipment, I think also was a challenge early on. We were fortunate that we never reached a point where we didn't have adequate amounts, but we had to be creative at times. There was a point where we were running low on face shields. as an example, and we enlisted members from the College of Engineering and our simulation lab to create 3D printed face shields to be able to help provide that eye protection early on. And then gradually the supply chain began to get better, but this was a huge potential limitation for many hospitals within our country. Another very important part of our response was this was, and I would say still is, incredibly stressful and challenging and disruptive for all of our healthcare members. And so both what's happening at work as well as within the community. And so we did a lot of effort to maintain the health and well-being of our workforce. We've done weekly town halls with upwards of 1,000 to 2,000 individuals just to answer questions that our staff may have. We've developed a peer-to-peer support program. Our psychiatry department has offered free counseling to any of our employees. We've done mindfulness and wellness sessions. And again, a lot of this is we have to be able to take care of our workforce, make sure that they feel safe in providing the care that they are doing, as well as take care of their overall well-being so that they can continue to provide the excellent care. In our experience, we also have seen certain vulnerable populations that have been more directly impacted. When this first began within our region, it unfortunately really landed in our long-term care facilities or our skilled nursing facilities, where you have a very vulnerable patient population. And so early on, we saw this significant impact in our older population within our community and higher rates of mortality in that setting. We subsequently have seen impacts within our homeless population, as well as our communities of color, who have been disproportionately impacted both in terms of the number of cases as well as hospitalizations and deaths. Recognizing also that we had limited access to testing in some of these populations, we've developed mobile vans that go out to different communities to provide testing. And we partnered to go into our homeless shelters to do testing. And across from Harborview, again, which is our county hospital, we have a shelter where we were able to convert it so that individuals who are awaiting tests or had COVID-19 and didn't need to be hospitalized had a place to go to limit potential risk of transmission to other individuals. This is an overall curve of the number of patients we had within our hospital dating from March 19th through June 6th. And as I mentioned, we peaked out at 122 patients across our 4 hospital campuses. That peak was sustained for over 2 weeks as we flattened that curve. And it's been a very, very gradual reduction in the number of cases within our hospitals. Right now, we have less than 20 across our 4 hospitals, which has been a huge success and has allowed us to resume the care for our non-COVID-19 patients as well. This is just an example of testing, both the PCR testing, where we have done with it through our lab almost 140,000 tests. We also are monitoring the proportion of tests that are actually positive. And when we were at our surge area back in early April, it was about 10 to 12% of the tests that were sent were positive for COVID-19. That subsequently has dropped down as we've seen better control within our community. And so on this date, out of 2,000 tests, almost 2% were positive. Now, this experience is different than other parts of the country. If you look in New York as an example, we saw very early on that upwards of 30% of their tests that they were sending were positive, and we knew they were going to have a much more challenging problem just because of that higher proportion of positive tests early on. Now, that's the PCR that actually tests for the virus. So this is the nasopharyngeal swab that's done on a PCR test looking for presence of the virus. We also now are offering serologic testing, looking for the immune response to potential infection, and does that individual have antibodies? Now, this test right now, we are still learning how best to use it. It is best, I think, from a population standpoint to really look at the prevalence of infection within your population as opposed to for the individual patient, because again, it shouldn't be used to make the diagnosis of acute infection. It's really looking to see, did you potentially have infection in the past? And it takes typically at least 14 days for the antibodies to develop. A typical scenario would be someone who maybe back in February or March had a flu-like illness. They didn't get tested at that time, but are now wondering, did I have COVID-19? And the serologic testing would help them. What we don't know yet is that, does a positive serologic test correlate with immunity or preventing you from getting reinfected? The studies for that are ongoing. If that becomes what we hope it will, that it does correlate with immunity, then this may have further implications for our population. Now, within the Seattle area and Puget Sound, Washington State, we estimate only about 3% of our population has been infected to date. That means that we still have a very large population of individuals who haven't been yet exposed to this virus, and that gives us pause as we go throughout this summer and particularly head into the fall and the next respiratory virus season, where we do anticipate another surge of cases. On the bottom here is just some early experience with the serologic test. Overall, our lab has done 29,000 tests within our region, including surrounding states, and 4% of the tests have been positive. We now are offering this as part of our employee health services for all of our 28,000 employees at UW-Madison, because we want to see what's the proportion of our healthcare workers who may have had COVID-19. And so far, out of the first 1,000 that have been tested, it's at 2.4%. So again, pretty low numbers overall. Here's just an example looking locally within King County, which is where Seattle is. The number of cases on a daily basis on the top right, showing the number of positive cases on a daily occurrence. And you can see that we peaked at the beginning of April and then have gradually come down. There is concern, as you've seen certainly in the media. COVID-19 and this pandemic is one significant stressor. We've also had obviously financial and significant community stress from an economic standpoint. And now with the really unfortunate, brutal murder of individuals by police within our country, we are now seeing a lot of protests. And in that context, mass gatherings. And one of the questions for us will be, what impact will these mass gatherings have in terms of potential increase in number of cases? On the bottom right, we show the number of hospitalizations across our county. And this is not just within our system, but all of our hospitals within the county. And in the upper left, I just showed you that the darker blue are where there are a greater proportion of positive cases per 100,000 residents. And what we've seen is a shift towards South King County, where we have more communities of color and we have more multi-generation families, where we have multiple generations that are living together. And we believe that that is a potential increased risk of why we're seeing more cases there. I mentioned the disproportionate impact on our communities of color. This graph shows in the gray bars the percent of the King County population by the different race and ethnicity groups. And you can see in the blue bars the percent of COVID-19 cases. And we're seeing a disproportionate number of cases in our Black community, our Hispanic, Latinx community, our Asian, as well as Native Hawaiian, Pacific Islander populations compared to our white population, when you look at this in terms of age-adjusted rates per 100,000 residents. And again, we are trying to target our efforts to help support these communities here locally. Unfortunately, within our healthcare system, we have baseline healthcare disparities with many of these populations, and this pandemic has just exacerbated and made even more visible those healthcare disparities. And so we all have a lot of work to do to try to address these. Now, our county has also set up a dashboard where they are looking at key indicators, and I wanted to just highlight some of these. Some of these are looking at the overall COVID-19 activity in our region, And one of them, the second one down, is the reproductive number. This number is basically stating for every number of cases that you have, how many new cases do you transmit? And when that number is less than 1, then you typically will see a reduction in cases, and that's what we're seeing in reduction of cases, hospitalizations, and deaths. We also look at our healthcare system readiness down at the bottom in terms of the proportion of beds within our community that are occupied, as well as the proportion of beds that have COVID-19 patients. At the height of our surge, it was about 10% of all beds in our county, and now that is below 5%. I mentioned earlier that we postponed our elective surgeries and non-urgent procedures, and we did that in an all or none effort, and I'll show you that data here momentarily. We are hoping that by using these metrics that we can have a more sensitive dial approach as we see the surge in the fall, so that we can respond to providing care both for those patients with COVID-19, but also those without COVID-19, and do this in a more sensitive manner than what we did in our initial preparations for this pandemic. This is a amending proclamation from our governor. Originally, the governor postponed all those elective surgeries and procedures until May 18th. Going forward, we believe we have more flexibility to provide care for both those COVID-19 and non-COVID-19 patients, both in our conventional care phase, where when you look at staff, space, and equipment, you're at your normal daily levels. But even in a contingency care phase, where maybe you have to adjust your staffing or your beds or your equipment from your daily routine, maybe you're caring for ICU patients in your post-acute care recovery area where normally your post-surgical patients would go. But as long as we are able to maintain our surge capacity of at least 20%, we can continue to provide all necessary care and not have to cancel elective and non-urgent surgeries. This is going to be very important both for providing that care and also for the financial stability of our healthcare system. I mentioned the Institute for Health Metrics and Evaluation earlier. I just wanted to share this tracking as they look at the impact of physical distancing or social distancing in the different states within our country, and then look at the estimated number of infections. So if you look at Washington State on the far upper left, Washington State has done a good job in changing mobility. At the peak, we had a 50% reduction in mobility of individuals. That is now about 35% as we begin to lessen some of those restrictions. But our incidence of infections per 100,000 residents is also among the lowest compared to many other states. And again, I think those go hand in hand. One of the things as we reopen that has been clear is that we may say we're open for business, but do our patients feel comfortable in coming back for the care? And so we have approached this in a bundle of activities to create a safe environment, including hand hygiene, maintaining physical distancing. So in our waiting rooms and our clinics, being able to shift our workflow and maintain that 6-foot distance. Personal protective equipment has evolved over the pandemic to now where we require universal masking of all of our healthcare workers within the clinical environments. We also really want to have all of our patients and visitors wear masks as well. And again, to decrease that risk of transmission, particularly if people have not yet developed symptoms but may be infected as we've learned more about this virus. I talked about the laboratory testing before. And again, we're very active in research activities, both in clinical studies of novel therapeutics as well as vaccine development. And then obviously our partners in keeping the environment clean are absolutely essential. And so as we often do with infection prevention, we bundle all of these activities together to create a safe environment. I'll go through a few slides here just to show the impact of COVID-19 within our health system. So this is looking at 3 of our hospital campuses and looking at the average daily census or number of patients. And you can see during COVID-19, we had a reduction in 34% of our inpatient volumes, which was really when we started to postpone those elective surgeries and procedures. This is looking at our emergency department volumes. And again, from baseline, we saw a significant reduction. One of our concerns is that individuals who may be having a stroke or even a heart attack are not coming in for the care that they need, let alone less serious conditions. And although we've seen some increase here, people, I think, are still afraid to come into the healthcare system and worried about acquiring COVID-19. This is an example of what we've seen in our clinics, where in our clinics comparing baseline in blue, April, and orange, and then May in gray, that overall we saw a reduction in April of 46% visits within our clinics, with specialty care being more impacted than primary care. And then that has gradually improved in May, but we still are at about a 33% reduction in our clinic volumes. And we shifted telehealth in primary care to upwards of 68% of the visits were by telehealth. This is just an example that I would say one silver lining of this pandemic, it pushed our telehealth capabilities ahead by well over a year. Prior to COVID-19, we had about 300 providers who were doing telehealth visits, and they were doing around 200 visits a month. In March, we did 14,000, and in April, we did over 30,000 visits by telehealth. So this was a phenomenal increase, and now 2,500 of our providers are able to do telehealth visits. And we've shifted from a credentialing standpoint from making that as a special privilege to now a core privilege, where it's just going to be part of how we practice medicine going forward. I don't think we will ever be going back to practicing medicine the way we were at the end of 2019. Telehealth is going to be and will continue to be a very large portion of how we care for patients, particularly within the clinics. This is an example of what happened with our surgical volumes. And so the yellow bars are the budgeted volumes. And this is at our UW Medical Center that has two campuses, both Montlake and Northwest. And you can look at the surgical volumes and that dramatic drop by 65% as of March 16th. And then that gradual increase now as we resume elective and non-urgent surgical procedures. Similarly, at Harborview, which is our trauma hospital and county hospital, they also saw a significant drop. They have increased a little bit more quickly because as people become more mobile and driving more, we start to see more trauma. And so they're having a little bit more quick impact on their surgical volumes. But this is just a reflection of what we've experienced here within UW Medicine, both in our clinics as well as in our ORs. And at this point, I'm going to pause, and I'd be happy to either ask or answer any questions now or after further presentations. And again, thank you very much for your time.
Thank you very much, Tim. That is a very detailed presentation, quite interesting to listen to. So we had reserved question and answer to the end of this presentation. However, maybe you can comment a little bit on telehealth challenges that you may have experienced at UW, especially now that you've had a surge up to about 30,000 clinical visits. What are the specific challenges before we move to the next presenter?
Yeah, so happy to answer that. You know, as I showed, we had a telehealth platform, but it was much more limited. We did a couple of things to make it easier for our clinicians. One of the things prior is that we did telehealth through Zoom, but then they had to be in a separate screen for Epic in our medical record. And we were able to integrate those. So now that they can do telehealth directly through Epic and have that connection. So it's a lot easier for our providers. So there are some technical components. We also brought in new technology to allow us, for instance, to do tele-ICU. So one of the things we realized when we started to see increased critical care patients within our different hospitals is that if we weren't able to provide adequate in-person staffing, could we provide critical care telehealth support for those clinicians as well as for hospitals outside of our region. We also shifted, we had already a network through our antimicrobial stewardship team with all of our small hospitals within Washington State. And we transitioned that program to more of a COVID-19 education and case review format to help really promote that information widely. The other piece, as I mentioned, we only had about 300 providers who actually had been trained to do telehealth. So our team put forward an electronic training module for which people could do that training very quickly. And that's how we were able to go from 300 providers to over 2,500 providers really within 2 to 3 weeks. That was done as emergency privileging because we had a declared state of emergency. We have now shifted that through our credentialing process to a core privilege so that going forward, any new clinicians that join our system will have to do that training as part of their onboarding, and it will just be part of their routine process. And so there were some technical components that we had to do to make it easier, and then we had credentialing and training components to really scale that up. But it had been really well embraced by our clinicians.
Wow, great. So at this point, I'd like to introduce my co-host, Dr. Nancy Ngumbao, who will take it from here until we reach the Q&A section. Nancy?
Thank you very much, Timothy, for your presentation. Really, really good presentation. And even as you're presenting, I'm even trying to see what we can adapt from your presentation to work in our setting. Right now, I'd like to invite Dr. Paul Mbuvi to make his presentation. Then after that, we can proceed to the question and answer section. So feel free to type your questions on the question and answer chat box, the question and answer column. However, if you also want to ask your question, you can raise your hand, and after the presentations, we'll be able to unmute you and allow you to ask your questions. For queries about CPD, kindly email us on knhcpd@gmail.com. Otherwise, Dr. Mbuvi, you can start your presentation.
Okay, thank you. Let me just share screen. Okay, hi, as you've heard, my name is Dr. Mutua Mbuvi. I am a medical officer. I work at the Mbagathi, the Kenyatta National Hospital Infectious Disease Unit. And so I'm just going to give a brief outline of what we have been going through from the time when we got our first confirmed case. That was on March 13th up till today. We have 3 centers that are running for the KNH team, basically for our IDU facility, which cater exclusively to confirmed cases of COVID-19. So we have our critical care unit, we have our isolation unit at Mbagathi, and we also have what we call our daycare center, which basically is for healthcare workers who get confirmed as COVID positive patients. That's how we usually take care of them. The basic generalities of it is that we have the staffing capabilities currently are quite good. We have 3 specialists who are all trained in infectious disease. And we also have backup from the critical care units, the respiratory and infectious diseases unit, the team of medical officers, nurses, pharmacists, counselors, lab techs, and physiotherapists. The counselors are actually more than 4. We're actually currently at around 15. I just need to update that. So like I said, we started on the first case that we got was on 13th of March. Now, since then, we have triaged a total of around 1,300 clients. Of this, we had around 40 who were discharged without testing. This was prior to the time when we were yet to have a proper case definition management from the Ministry of Health to let us know who we can actually quarantine and who needs to be tested and admitted in the facility before being discharged home. So at this particular point, we were using the main case definition, which was basically including history of travel from outside the country or having come into contact with someone who has come from a country where COVID-19 has actually been confirmed. So up until around the beginning of this week, we have had a total of 817 admissions. 530 have been confirmed negative, but some of these are not captured in the total admissions because some of them were actually just, the swabs were taken and they were discharged to go home and receive the results on the following day. We have had a total of 184 confirmed cases. with a mortality of 13 cases, and we've taken care of 13 foreigners, and we have many patients with comorbidities, including HIV, diabetes, and hypertension. This is basically just a small graph to show how the distribution is. As you can see, most of our cases are between the ages of 30, actually from the age of 20 to 49, 59, that's where the bulk of our patients are coming from. And in keeping with other places that we are seeing more male patients coming in as compared to the female population. This is just a graph showing the ranges of the ages as per the last time we actually went through this, checking on the side of how many, the age distribution of these patients. But now, given the point where we have reached now, this is like the third month into this pandemic, and our mortalities have actually kept increasing. And now we actually have a total of 13 mortalities. Two, as they have shown there, that 2 happened at our Mbagathi facility, 1 happened at our critical care unit, but the others happened to occur in other areas of the Kenyatta National Hospital, including the accident and emergency department, the medical critical care unit, the pediatric critical care unit, the general medical wards, and what we call Ward 42, which is also one of our holding areas for suspected cases who need to be waiting for their results at that time. So our mortality is actually going up. And this is what the interesting thing that is happening. As you can see, the same thing with mortalities. We have more male deaths as compared to female. From the total of 13, actually 10 of them are male, only 3 are female. Are the ones we have actually had the deaths at this particular place. And this is basically just the age distribution. From the ages of 0 to 1, we have 1. We had a pediatric child who died. And from 11 to 20, between 11 to 20, we currently have none has died within that age group. Also between the age group of 21 to 30. But now when you come to the age group of 31 to 40, we see that there have been a number of deaths also between the ages of 41 and 50, 51 and 60. But the bulk of the patients who have actually passed away with patients who have been diagnosed with COVID-19 actually above the age of 60, which is kind of in keeping with what has been happening in the rest of the world. So one of the challenges that we face at the moment at our facility is our testing capacity. Our turnaround time for our results is 24 hours. And I had the previous presenter mention that even them initially when they started, they had a turnaround time of, I think it was up to 3 days. And they were able now to, once they had the capabilities to test themselves, they were able to cut this down to around 6 hours, which is one of the things that we're really hoping that we can get to, because now this will help us to be able to initiate treatment of suspected cases much faster, and we'll know how to handle these cases at a much better rate, and also be able to help the other units in the hospital be able to take care of the patients who are coming in as suspects, that we can actually have the results on time, and also know when do we need to call in the infectious disease team to come and take over the management of these particular patients. And so those are some of the challenges where we've had, including the turnaround time for our lab, the large number of asymptomatic patients who we have been seeing, who have been admitted in our facilities. We've also had a lot of stigma from both the healthcare workers and the patients. Then also dissemination of information regarding COVID-19 has also been a challenge for most of the healthcare workers. Now, in terms of our preparations and also what are the things that we have done to deal with some of the challenges that we have actually faced, is that there are more testing centers currently. We have KEMRI, we have we also have the KNH facility itself in collaboration with United are also doing the testing together with the National Influenza Center, which is also part of the team that is helping us. And also a huge part of the private sector also, who are also carrying out these testings, are also helping us in terms of dealing with our patients as well. With the Ministry of Health, and now with the advent of home-based quarantine and home-based isolation care for patients who are eligible, this has actually helped us to decongest our facility, and also helped us to actually now be able to take care of the really sick patients who actually need to be in hospital, apart from having the asymptomatic stable patients who have been there for most of the times. In terms of surge preparedness, when we operationalized the emergency ward 42 to cater for patients who are suspects who are yet to get their results, this has been part of the preparation for surge, for coping with the high numbers that we expect to be coming, and also converting the Mbagathi facility to become purely for confirmed cases only, as opposed to having both suspected cases and confirmed cases being admitted at the facility. And we also have our ICU facility, which is at the KNH. This currently has a capacity of 6 beds, with also capabilities of carrying out dialysis, but there are plans to increase this capacity because we believe that as time goes by, as the cases keep getting more and more, we will be having a whole lot more patients who are coming in who require critical care. And that's the need for us to increase our capacity. And also collaboration with other facilities and other hospitals, including the Kenyatta University Teaching and Referral Hospital, which has been one of our main collaborators in terms of patient care, and also how we relate in terms of just basically patient care. And when we are at capacity, we are able to offload some of our patients to this facility, and the vice versa. When we have the space and they have their capacity, they can actually discharge the patients to come to our side, and we continue with the care of the patients. So in terms of what you talked about in terms of knowledge and capacities, that now, like what we're having today, these webinars have actually been quite helpful and quite, I believe, quite critical in helping us manage the COVID-19 cases, especially when we have other facilities giving us their presentations and telling us how they're dealing with the various challenges of the patients that they're seeing, and how they've dealt with the challenges that they have. Also it becomes something that is also for us, we're able to learn a lot, and also helps to increase our capacity in terms of knowledge. And also, one of the major concepts, that one of the major things that we've seen is the advent of stigma. And I believe this something that is seen in both for the patients and also for the staff who are dedicated and working in the infectious disease unit. And this stigma is something that we noticed, and it's become, at some point, it was becoming quite chaotic. And at that point, the hospital got more psychologists and clinical psychologists and also counselors to help both the staff and the patients be able to deal with this particular pandemic that we have. Although there is a lot of space that can be done, a lot that can be done by, especially by the Ministry of Health, and even for every single person who's actually attended this webinar, is that we can also be able to spread this information out there and help people to, and actually help to destigmatize this condition, so that once people can understand how this thing is spread, and the fact that in as much as someone can have a COVID-19, but there are chances that these people are actually going to get better, they're actually going to get healed. And it's unfortunate that some people die, but this is a disease that does not discriminate, if I can put it like that. It can get to anyone at any time, and anyone can become a victim. So just helping to pass out this information out there to the rest of the population, so that they can understand how this disease process is and how this pandemic is affecting us. This can also help to reduce the amount of stigma that we get for both the staff and the patients who we see at our facilities. I think I had a very brief presentation, which is basically just that, but we have the Q&A section coming up. So I'm available to answer any questions or to give any clarifications, or even to add any more points that I may have missed in this particular presentation. So thank you. Back to you, Dr. Ngumbao.
Thank you very much, Dr. Pombo, for your sharing your experience, the Nairobi KNH experience. Right now, we'll dive directly into the question and answer section. And I'd like to ask Professor Omondi Ogutu to ask his question. Together with the other people, there's Pauline Omondi, Cecilia Kipto, Phyllis Waithera. Feel free to ask your questions.
Thank you. My question goes to Timothy. Thank you for a very good presentation, which has captured what you have been doing in Seattle from the time the pandemic started. I was quite intrigued by your opening statements when you are doing targeted testing for travelers who are coming in. Were you doing a general testing? Were you targeting particular groups of people depending on where they were coming from? Or were they people who already had got signs and symptoms? Or what criteria were you using? And where was the testing being done? At the airport or in the designated areas where they were, or were they quarantined? What exactly happened? Because that, I think, is the key area of identifying the people who are bringing in potential persons who are then transmitting the disease to the other people.
Mhm. Now, that's a great question. When you think very early in the pandemic, if you think back to January, when it really, before it even was called a pandemic, the number of cases, as best we knew at that point, was really limited to China, right? It started in Wuhan City and then spread further within China. And so very early on, the recommendations in this country were for travelers from China that came in that had symptoms, so fever, cough, respiratory symptoms, and had traveled from China within the last 14 days to test them. And this is where our home assessment teams would work with public health to go out there. They collect the nasal pharyngeal swab, bring it back to the lab and test them. But those were very small numbers of people. And that changed once we saw that, one, we were seeing it in other countries, right? As well as now locally. And so at this point in the pandemic, because essentially every country in the world has been affected, that travel history for us is no longer relevant because we have the cases right here in people who haven't traveled. So I think travel history can be very useful very, very early on in an outbreak when the number of cases are really from a confined geographic location. But now that it's spread across the world, I don't think the travel history really has as much relevance, at least for us in this country. And so you'd have to think about what your local situation is in terms of where may be higher rates of infection or lower rates of infection. But ultimately, unfortunately, you have to assume that anyone may have it if they present with potential symptoms.
Thank you very much. I'll ask this question that has been asked by Teresa Kinyaru. Is there a follow-up protocol for patients who've recovered? I think this question is directed to both the presenters, whether we have a follow-up protocol for patients who've recovered and what does that look like? And do we have patients who have been reinfected?
Yeah, maybe I can start, at least from our experience. When we have patients, let's say within the hospital, as they continue to recover, and maybe they have to stay in the hospital for other non-COVID-19 issues, we require 2 negative tests before we clear them from the isolation precautions. Some of our long-term care facilities, if patients are going back there, also require testing prior to discharge to ensure that they are negative. One of the things that we have run into, though, is people can shed this virus for a long time. We've seen people, even with minimal symptoms or no symptoms, have positive tests even 6 weeks after the onset of their infection. And so that creates challenges in terms of how do we actually clear them to go to that next level of care. And so we've also tried to identify, as it sounds like you've done locally there as well, where can patients who are COVID-19 positive but don't require hospitalization go to continue their recovery. And so we've been working with public health to identify a couple of different locations where those patients can go for ongoing recovery.
Okay, so maybe to give now from our perspective, follow-up protocols for patients who get discharged. When we initially began, we kept the patients and up to a point where a patient will be admitted and will be tested after 14 days. Now, if the test results came back negative, we will do a repeat test after between 24 to 48 hours. And if we got a negative result of that one, we will have 2 confirmed negative results and we were able to discharge this patient. But as Timothy has said, there are those cases where patients keep shedding, that even after you take the tests, even 6 weeks later, they're still turning positive, and this has been presenting a challenge. And so for most cases, there are a few patients who actually been followed up. We have had one case of a patient who came back with the possibility of being reinfected. But what happened with this particular patient is that after receiving his 2 negative results from our facility, he wanted to travel out of the country. And part of the for that, he actually had to be tested at a different facility. And when that test was done, it actually came back as positive. And this patient was sent back to us. So when this patient came back, a test was done again after another 24 hours, which was found to be negative. And a second repeat was done, which was also found to be negative. And thus we were comfortable enough to discharge this patient to be able to leave the country at that time. So apart for proper protocols in terms of how to follow up these patients once they've been discharged, once they have their 2 negative results, they are considered to be cured, and we actually give them our contacts for our facility and ask them in case of any development of any new symptoms or any other questions that they feel that they need to be seen by the clinicians, then they can actually call the number and we'll be able to attend to them. That is part of our follow-up. The thing is, we have had a lot of patients who have actually been discharged. But so far up until now, apart from that one case who came back with the test results actually showing that another positive test from a different facility, we have not had any issues in regards to that particular event. Yeah.
Thank you very much. Michael, Karume, Cecilia Kipto, Wilfred Ochieng, kindly unmute yourselves and ask your questions. In the meantime, questions to both panelists. Many people are asking about the issues of COVID-19 patients and their need for ICU care and how that has been going. So, what's the proportion of the patients in Seattle and in KNH who have required respiratory care, and what is the outcome of those patients?
So I would say if you look overall at the number of patients that have COVID-19, probably about 80% of them do well and don't need any further medical care. About 15% have required hospitalization, and probably about 3 to 5% require ICU level of care. And those patients who require ICU care, there are those that very quickly progress and become so ill that unfortunately they are going to die despite maximum efforts. And we've worked a lot with our palliative care teams to help support them in that process, particularly in our older population. There are also patients that have been on mechanical ventilation for prolonged periods of time, and our average length of stay in the ICU is about 2 to 3 weeks. But there are patients who have come off the breathing machine and have done well. We've also had patients who have required ECMO because of severe hypoxia, and we've had a number of those patients. And of those, I would say we've had a few that have been successful there, and some unfortunately who have died. It's an interesting illness in that while it can be very mild for many, you then see people who really have this profound low oxygen levels and really become quite ill, and often can do so very quickly. They can be well and then all of a sudden just really turn and become very ill very quickly. But overall, I would say it's probably about 3 to 5% that have required ICU care.
Okay, on our local experience, from what we have seen at KNH, basically I like to agree with Timothy. A majority of the patients we have seen, they can equate it to the same around 80% have actually been asymptomatic patients who have been stable, no issues whatsoever. We've been able just to keep them isolated and been able to discharge them to go home. However, there is this percentage of patients who come in who are between moderate to severely ill. Now, from our experience, the moderately ill patients usually tend to deteriorate and become severely ill patients. And sometimes we do get these patients who are severely ill and may require critical care. One of the thing we've noticed that in the patients who have actually required to be mechanically ventilated, unfortunately, the 3 that we have had, unfortunately, all of them have passed on. And we've been trying to figure out what could be the cause of this. But as we've said, there are those patients who are quite asymptomatic, and there are others who just basically get a very severe form of this disease, and at times deteriorate quite quickly to a point where by the time you actually get the intervention in place, it's already too late. So that has been our experience, especially with intubated patients, and some of them whom we've seen usually have these comorbidities. They're either diabetic, they're hypertensive, but recently we have had one patient who came in, was a relatively young man, 41 years of age, and no known comorbidities. He had no history of smoking. The symptoms that he presented with had started like a week prior to him showing up at our facility, and he had been managed by, he has been using over-the-counter medications, antibiotics, basically, because he thought he had a bacterial infection. But as time went by, the symptoms did not dissipate. He still had the runny nose, still had the cough, and this progressively became worse to a point where now, one day prior to him showing up at our facility, he was now developing difficulty in breathing. And when he came on checking his pulse oximetry, on room air, he was actually saturating between 70 and 80% on room air. So we started the initial part, put him on a non-rebreather mask, but we were not able to get the oxygen saturations up to the level required. And for us, we don't have the capability to do CPAP. So the only alternative that we had for this patient was just to intubate and mechanically ventilate this patient. And unfortunately, we lost him. So that has been our experience, especially with the very critical ill patients. We're yet to have those ones who have been intubated and have actually come off the vent and actually done well. So we're still yet there, but I still believe with our numbers still rising as the days go by, we may end up seeing more and more of these cases that require critical care, and we may actually be able to see now these patients who maybe we may be able to ventilate them and give them mechanical ventilation, and they may actually get off the vent and actually stabilize. Hopefully we'll be getting such cases. Yeah.
Thank you very much. I'd like to give an opportunity to Jessica Wambani to ask your question, followed by Elizabeth Okundi, Yuda Odhiambo, or Cecilia Kipto. Kindly unmute yourselves and ask your questions.
Thank you very much for giving me the chance. My name is Dr. Wambani, and I would like to ask Dr. Nevilit from USA. You said that at first you were doing house visits to test people. What cadre of health workers were you using, and what are your numbers of those health workers? Is it a big number? And how did you look at the target population within the community? The next question I would like you to answer also is that you said that you were doing antibody testing. What criteria were you using for this antibody testing? And yet you also say that it was non-specific to coronavirus. So what was the use of the antibody testing? Thank you.
Great, thank you. So the first question regarding the home assessment team, this was very early on when it was really focused on those return travelers. And so these were very few in number. It may be like one individual or two individuals a day. We had a team that was comprised of a physician and a nurse who would go out, and then we had a third individual who would help monitor them in terms of both how they put on their personal protective equipment and, more importantly, took that off so that they didn't run the risk of contaminating themselves. So they were small teams, a physician, a nurse, an observer, that would go out. And then once we started to see an increased number of cases, we stopped doing that because we just wouldn't be able to keep up. So it was very useful early on when we had small numbers in the community, and then we stopped that. In terms of the serology test, it actually is specific to the SARS-CoV-2 virus and the immune response to that. So it is not non-specific. It actually is very specific. What we don't know is that if we detect antibodies through this test, and we use a test by Abbott, does it mean that you have immunity to prevent future infection? That's what we don't know yet. I would also say that there are a lot of serologic tests out there on the market, and some of them are not very good. The one that we have, our lab testing compared to all of them, and we believe both the sensitivity and specificity are over 99%. And so we believe this test that we're using is a very good test. It is specific for COVID-19, but it can't be used for acute infection. So if you have concern for acute infection, you have to do the PCR testing from the nasal or nasopharyngeal swab. So right now, until we know whether this correlates to immunity, we're really using it to test populations of individuals to see, well, how prevalent was the infection within our community, and how much potential protection is out there, or how many, if you look at the other way, how many vulnerable patients we have. But for the individual patient, it's not clear that there's a good medical benefit for changing how you would manage that particular person. I would also add, we don't use it to determine whether you should work or not. We don't use it to determine what type of personal protective equipment or what you do at work. So it's still in the very early phases. And so for most people, it probably isn't that useful. It is more useful from a population study.
Thank you very much. Right now in Kenya, I know we are gearing towards home-based care and trying to see how we can take care of probably the symptomatic patients from home. So a lot of the questions from the attendees is, are you currently doing home-based care, and what's the protocols around the home-based care? So whom do you agree to do home-based care, and who do you admit in the facility, and how does this look like even in terms of follow-up?
So typically, let's say if someone has symptoms and if they are more mild, I mean, we ask them to contact their doctor or their provider. They could do a telehealth visit to evaluate the severity of their symptoms. And if they are not severe, then they can be managed at home. You know, again, there's no treatment, so it's really watching for worsening of symptoms. What we don't have in good place right now is we don't necessarily always have home oximetry to be able to measure their oxygen level. So much of it is by having a conversation with the patient and checking in with them. So I would say that we don't have a robust home process. We have that for people who are not that sick and contact the provider, and we can manage them through telehealth. When patients are discharged from the hospital, we can also follow up with them over those first few days and make sure they're continuing to improve. And we can also do that by telehealth. So we've probably used more telehealth to follow up with them as opposed to sending people to their homes.
Thank you very much. Elizabeth Okundi, Yuda Odhiambo, Ahmed Omar, Omidred, kindly unmute yourselves and ask your question.
This is Elizabeth Okundi. Thank you so much for giving me the chance to ask the question. And thank you so much to the presenters for the lovely presentations and the amount of knowledge we have gained. And it's been an eye-opener. Now, two of my concerns have already been addressed. I was concerned about the drive-in testings and the possibility of reinfection. Now, my only other question would be to Dr. Mbuvi. I was looking at the staffing when you gave out the staffing, and I saw that there was no dietitian or clinical nutritionist in your staffing. Now, my worry is that we know for a fact that our immunity is important, and that optimal nutrition helps in at least making sure that the disease does not progress very fast. As you were talking, answering another question, you said that 5% of the ICU were patients who progressed very quickly in order for them to be in the ICU. So if the disease is progressing very quickly, would it be prudent to have dietitians and nutritionists at the beginning when we have the stable patient that we have in the hospital? And also to address the comorbidities in order for them not to, in order for us not to allow the patients to have their disease progress to stages that we could have avoided. And I'm concerned about the energy expended and the nutrients that need to be taken, knowing that the coronavirus is an RNA virus, and we know that the protein levels and the energy levels are interfered with. And as the disease progresses to being critical, then we expend more energy. So I was wondering if in our staffing, we have the dietitians.
Thank you very much, Elizabeth. Dr. Paul Bove.
Yes, thank you so much, Elizabeth, for that question. Unfortunately, I had not included them in my slide presentation, but we do have a dietitian and nutritionist who cover our units, and they actually are the ones who decide on the diet plans for the patients who are there. Now, like I said, we have a good percentage of our patients who actually have comorbidities, including diabetes and hypertension, and also they're also HIV positive. We also have those cases. So yes, we do understand that nutrition is quite important for them. We do have a nutritionist on board who ensures that they actually get nutritional counseling on a daily basis, and more so for those who have comorbidities. And also they are the ones who also help to plan the diets for these patients, especially the diabetics, and they also liaise now with our, I'll call them our kitchen staff, the people who actually now prepare the meals for these patients, so that they know which patient requires which particular foods or which particular nutrients at that particular point. So yes, we do have nutritionists who cover the infectious disease unit at KNH, and they actually do see all the patients who are within the facility, but they pay more of their attention to the ones who come in with comorbidities. Thank you.
Thank you very much. Even as the attendees unmute themselves to ask the question, there's a question that has been asked by Joseph Githaiga in terms of how do you maintain patient confidentiality during telemedical consultations? And have you encountered any medical legal challenges with telemedicine?
Yeah, that's a really great question. The Zoom platform we use is a one that's designated in terms of privacy and approved by our privacy officers. And so it is very secure, both from an IT standpoint. And we also then, as we do telehealth visits, one of the things that's required in this country is actually an informed consent. So at the beginning of the telehealth visit, the provider has to consent and get permission from the patient to perform the telehealth visit, and then document that informed consent as well. But we've worked a lot with our IT security people to ensure that we have a secure platform to protect patient privacy. So that has not been an issue.
Thank you very much. Vita Christopher Denish Omoro, please unmute yourself and ask your questions.
Thank you so much, Timothy and Bhuvi, for that wonderful presentation. My concern was this, whether I had it well. We have those patients that have been taken or recovered and discharged from the hospital. Like Timothy said, that they use the public health to follow them up, if I got it right. I just wanted to know how efficient, or what is the feedback that they get in the follow-up done by the public health staffs that they employ to follow up these patients. To Dr. Mbuvi, I just wanted to, from what explanation that you have given, don't you think it is more important also to use public health staffs to do the follow-up? Because at times, following what we always see in our country with the fear that people have. So there are some people who could.
Seems as if we've lost Dennis. Mildred, Ovita, Christopher, as Dennis is reconnecting.
While he reconnects, I can comment on, at least here locally. So public health, when they do follow up, they're not following up for the medical care of the patient as much as they are following up for the contact tracing now. Meaning that if they have identified someone who is positive for COVID-19, to then evaluate who else they may have become in contact with, and then coordinating to have those individuals also tested or do home isolation. So the public health role is really much more from a contact tracing perspective. The medical care side is more by their primary physician or provider, and usually through either telehealth or phone call, or they could have them come back into clinic to be seen as well. But I would just separate those two aspects because the public health is really not involved in the direct medical care, at least in this country.
Okay.
Yes, Dr. Mbube?
Yeah, so I got part of his question in terms of asking why we are not utilizing the public health team in terms for the patients when they leave the facility after we discharge them. Why we're not using the public health team to do the follow-up? For most part, we do have a public health team that is involved with the day-to-day runnings of the facility, and also they are part of the team that helps us with. They help us sometimes in terms of contact tracing for a patient who's found to be positive. But the current public health officials who we work with at KNH facility are with us to help us now in the management of the facility itself, and also maybe just to do the contact tracing for particular patients who actually get to be confirmed once they are inside Kenyatta. But for the patients who we get from outside, the Ministry of Health has an elaborate system where they do the contact tracing and also surveillance for any other person who they believe could be a contact or someone who needs to be followed up even after discharge. The Ministry of Health has an elaborate system where they have a team that actually does that. So on our part, we are not tasked with that particular aspect of the case management of patients, because the Ministry of Health actually does that for us.
Thank you very much. A number of questions are coming in terms of the issues of healthcare workers. In Seattle, what's the proportion of healthcare workers that have been infected with the COVID-19, and what support do you offer to the medics or the healthcare workers who've actually contacted COVID-19 from probably managing patients?
Great. No, thank you for that question. One of the things early on that we did was to offer testing for any of our employees who had symptoms. And when you look at all the employees tested, the proportion that were positive was about 4.5% of all those tests. When we've been doing serologic testing now, it looks like maybe 2 to 3% of our employees may have been infected. When we know about those employees and we interview them, most of their exposure, however, is not from working within the hospital where we believe our personal protective equipment is providing them good protection. It's actually that they've had exposure either at home or elsewhere within the community. And in fact, what was reassuring early on is the percentage of positive tests among our employees was, as I mentioned, about 4.5% compared to 10% for the overall population. So if anything, we felt our healthcare workers had a lower rate of infection than the general population, which was very reassuring that the protocols that we were using, and we followed the WHO protocols in terms of droplet and contact precautions, and then we use airborne and contact for aerosol generating procedures or within our ICUs. But we have felt that the personal protective equipment has been very supportive. Now, we also, as I mentioned, from a mental health standpoint, we have peer-to-peer support because we recognize how stressful and challenging this time is. We offer mental health services through our psychiatrists and our counselors. And so we've tried to create a number of different venues where people can reach out for help, both physically as well as for their mental well-being.
Thank you very much. Faisal Ahmed or Ahmed Omar, can you unmute yourself and ask your questions? Even as they're doing so, a number of questions that have come through is regarding the issue of when you are giving your presentation, the way you raise the issue of the colored community are hit hard by COVID-19. And what would be the medical or the scientific reasons behind this? That's a question from Simeon Awor.
Yeah, no, that's a really important question. You know, and we look at race as a social construct, not a biologic construct. So I don't think there's a biologic reason. And as Dr. Mutawa said, this virus does not discriminate. What it is a reflection of is that communities of color, unfortunately, within our country, often have lower baseline access to medical care. So they may have worse diabetes, they may have worse lung disease because they don't have routine access or basic medical care. And so those comorbidities sometimes are more prevalent within those populations. And we also know that they didn't have as good access to either testing if they develop symptoms or access to care. So I don't think this is a scientific reason because of their race. It's more reflection of our overall healthcare system and the limited access to care that some of those communities have had, and greater underlying comorbidities like diabetes because of that lack of access.
Thank you very much. I'd like to give an opportunity to Dr. Maritim, is she still there, to make a comment if she has any? For the attendees who've raised your hands, kindly unmute yourselves also and ask your questions.
Yeah, my name is Jojo Witi from Kisumu. I'm asking this question in relation to gender. We kind of seeing so many males as opposed to females being infected. Is this the same to healthcare workers that are being that are serving in your place, Seattle? And is the infection rate the same as in other setups, as often more males are getting infected than females?
You know, in Seattle, we have not seen that sort of a differential between males and females. We definitely see underlying medical conditions as increased risk, and then I showed you some of the impact on race and ethnicity as we just discussed, but we haven't seen that sort of a differential with respect to gender.
Okay, we are almost coming to the end of this session. So for anyone who's raised their hands, kindly feel free to unmute yourselves and ask the question. There's a question here from several of the attendees in terms of predisposing factors towards COVID-19. So right now we know that diabetes, hypertension has has been shown, and previous lung disease has been shown to be a predisposing factor to the mortalities of these patients. Are there other morbidities like cancer or anything that predispose the COVID-19 patients to higher rates of mortality?
I think we worry about individuals who may be immunocompromised, whether it be from, as you mentioned, cancer. I haven't seen clear data within our HIV population, but that would make me worried within our transplant population. People who are taking other medications that may suppress their immune system, because we know that they're at increased risk just for viral infections in general. So I would worry about them. But the most common ones are, just as you pointed out, particularly the diabetes, underlying lung conditions, age, at least in this country, seems to be associated with worse outcome. Early on, we saw very few children with this. In fact, if you look at our pediatric hospital, at most they had 1 or 2 patients at any given time. So our pediatric population has not nearly been as impacted as adults, which is an interesting question. We are starting now to see more new cases in a younger population in that 20 to 40-year-old range, but I don't know if that's because we're doing more testing, where early on we weren't testing young people who otherwise weren't sick and requiring hospitalization because of limited testing capabilities. So that is not entirely clear whether that's just a shift in terms of who we're testing, but those are some of the things that we've observed.
Thank you very much. So a lot of the questions that are also coming is on the treatment protocol. So for patients who present at your facility with COVID-19, what do you use for medication? Have you used hydroxychloroquine, and what is the experience with its use?
Early on, and I think this is an important lesson. So first, there are no approved treatments in this country for treating COVID-19. Hydroxychloroquine was raised because of in vitro activity. And early on, we were using that more, including with people who had been admitted with mild disease. But subsequently, the studies have shown that it's not beneficial. And what we saw was increased risk of cardiac conditions, particularly arrhythmias or QTc prolongation. And so we do not use hydroxychloroquine anymore within the hospitals, and we believe that it didn't help the patients and actually may have caused harm. For those on the acute care who are not as sick, it's just supportive care. We're not using any particular medication. In the acute care or in the ICU, we use remdesivir, and remdesivir has been shown in early studies to at least decrease the time to recovery. There was a suggestion that there may be a benefit in terms of mortality, but not proven. So remdesivir holds some promise, but it still should ideally be done through clinical trial. We do have an expanded access program for that drug as well. In some situations, we've also used, through a study, convalescent plasma. So collecting plasma from patients who have had COVID-19 and recovered to be able to use their antibodies to help then treat someone with active infection. But we try to do all of these through a clinical study because there really is no effective proven therapy. Again, remdesivir has some benefits that we think, and so we're using that where we can within the critical care patients. But the hydroxychloroquine I would be careful with because of the cardiac issues that we've seen.
Thank you very much, Tim, for your contribution and for answering all our questions. Thank you also very much, Dr. Paul Mbuvi, for all for the educative presentations. Even as we come to the end of this session, would you like to give any parting shots?
this is Tim. I just appreciate the opportunity, and it's been great for me to be able to listen to what you're experiencing and just to share information. I think that's critically important, particularly when you have a new virus and a new pandemic. And just as we just spoke about, there's really no effective proven therapy. So we're all learning together. So the more that we can share information, I think that's wonderful. So thank you very much for your time.
Dr. Mbuvi?
Okay, thank you so much for the opportunity. It has really been a good learning experience, especially from Timothy's presentation. We have picked up some things that which we think we can be able to start seeing whether they can work on our end. I've actually really enjoyed the part of telemedicine in terms of following up of patients who are in the hospital or who are not COVID-19 related, that you can actually do telemedicine for them and actually see them from home, which is something that can actually be something that can be done even after COVID-19. It's something that we can be looking forward to. So thank you so much. Thank you for the opportunity. The questions that have been asked, thank you so much for them. They've also been quite educative to us in as much as we try to answer them. So thank you.
I'd like to give a sincere thank you to all our panelists that have managed to give us their presentations, and a sincere thank you to all the attendees who've joined this meeting, this webinar, even despite the fact that it's beyond working hours on our end. Thank you very much for being attentive and also for raising your questions. That said, we have come to the end of this webinar. I hope everyone has learned something coming out of this. Thank you very much. For inquiries about CPD, kindly send us an email on knhcpd@gmail.com. Tomorrow we will be having our webinar from 2 to 3:30. Otherwise, thank you very much. Have a good night for people in Kenya, and for the people in Seattle, good morning.
Thank you very much. Bye-bye.
Thank you so much as well. Good night.
Thank you very much and bye.